Good morning everyone. I welcome you all to the first hands-on live hysteroscopy training workshop organized by Vaunshdhara Fertility Center and Nagpur 𝗪𝗂𝗪𝗂𝗪𝗂 Society. So before we begin, I would like to introduce our team. Our Chief Operating Faculty, Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪 sir. Sir is a star faculty of international repute. He is an expert trainer and an authority in laparoscopy and hysteroscopy. We welcome you, sir. I request Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪 to welcome Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪, sir. Thank you, sir. Next, I would like to invite Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗍𝗪 ma'am, President Nagpur 𝗪𝗂𝗪𝗍𝗂𝗪 Society, for the workshop. We thank ma'am for her participation in our workshop and making it a huge success. Thank you so much, ma'am. I invite Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪 to welcome Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪 ma'am.
I have to be on the guard.
Next, our operating faculty, Dr. 𝗪𝗓𝗄𝗏𝗏 sir, Secretary NOGS, a vaginal and very well-renowned laparoscopy surgeon in vaginal surgery. I request Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪 to welcome Dr. 𝗪𝗓𝗄𝗏𝗏 sir. So, as all good things begin with a prayer, I would like to invite all the faculty for the traditional lamp lighting ceremony. Thank you everyone. Now I would like to invite the faculty, chief faculty, Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪 sir, to garland our patron and founder of Vaunshdhara Fertility Center, late Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪. Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪 was the pioneer and the first person, along with Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪, to start the IVF practice in central India. It is on their work and on their beliefs that we are where we are, and now we are celebrating 30 years of Vaunshdhara Fertility Center. Thank you, dear faculty. Now I would like to invite President Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪𝗂𝗧 ma'am to say a few words of wisdom before we start the workshop.
Without the mic.
Good morning all.
आजचा हा फंक्शन मला आठवत आहे की आम्ही वे बॅक समवेअर ॲटलीस्ट 15 to 16 years back we were here for IUI
Yep.
with madam. Reviving the old memories.
2005.
2005, yes. Reviving the old memories, the same hall, except madam is not there today. At the outset, I would like to thank Amol and congratulate the entire 𝐄𝐗𝐏𝐄𝐑𝐍 family for organizing this hysteroscopy workshop. We all know hysteroscopy is the need of hour. It's a daily needed intervention in our all infertility patients and other gynec patients. So it's very obvious that you all are learning here, all are welcome here. I welcome the faculty, Dr. 𝗪𝗓𝗪𝗧, our own 𝗪𝗓𝗪𝗧 members, Amol and Ashish for today's workshop. I welcome all the virtually joined delegates who have joined today for this workshop from 𝗪𝗓𝗪𝗧 as well as from other societies. So thank you for the opportunity. 𝗪𝗓𝗪𝗧 is getting associated with you. Thank you.
Thank you so much, ma'am. Now I would like to invite our Chief Faculty, Dr. 𝗪𝗓𝗪𝗧𝗪𝗧 sir, to briefly introduce the workshop session as what all will be there.
Good morning, everyone. First of all, thank you for that kind introduction. Respected Chairperson of the Nagpur Obstetric Society, Dr. Madam, Dr. 𝗪𝗂𝗏𝗧𝗪𝗧 sir, my very good friend Ashish, and all the delegates who are here, and Amol for this kind invitation. So, after a very long time, this is the first actual hands-on workshop that will be happening. So, it's almost like 2.5 years now.
Yeah.
So we were always missing the real physical workshops which were happening, and because that is actually the training that can happen. So just I was not aware that I am supposed to introduce what is to be happening in this workshop, but I'll just give you what actually should be done and what happens in a workshop. See, our brain has a typical way of learning, and if we know that model, it is already a very well studied model. It's called as Rasmussen's model, where there are steps how we learn things. Like when we are born, the first thing is we don't walk. We'll just try to get up, we just try to get up, we take support, and then there would be just the first step. So next time we take another step. So that time we would feel that he does not walk at all. He's just taking steps. But if you take an incision, it is nothing but small cuts. When those cuts are joined, it becomes an incision. So same way, we have to learn these small steps, and that is the level 1 learning which happens. So that is, it is called as the, you are getting, your brain is learning those steps which happens on the dry lab. So you have models where you are going to make these small cuts. So when you make small cuts, when you make circles, when you make zigzag lines, that is what is needed in your actual surgery. So don't underestimate that, I am not getting to do a real case. Real cases are everywhere throughout India. All doctors are just flooded with work, and you have to learn these steps. Secondly, nobody teaches us at the, like when we are driving or going in a car, we are just watching, and these things are getting imbibed in our brain. That okay, when I reach a signal, when there is a green light, I have to cross. Next is when there is a orange light, I have to slow down. Maybe red color will appear and I have to stop. So these things is in the second level of the learning process that is happening. And third is whatever our parents are talking, whatever our friends are talking, that things are getting into our mind. So all these learnings happen when you attend conferences or you are going on online classes, when you are attending lectures. Repeatedly some new things are coming into your mind. Maybe they are not required on that particular day, but it will help you in some way or the other. So these things are happening. The final step which happens is when you are in actual crisis. So for that we have to watch the videos of experts where they are managing these complications, like how they behave in crisis. So that is the final thing that can happen. And till now what was happening initially was only we had books, DVDs and attending conferences. The main thing, people were not progressing beyond that without just only the understanding was there. But when they go back to the OT, they were not able to perform the surgeries. Similar to what my teacher used to say, when I sing with some audio cassette, I am very good. But as soon as they put off that audio, I sound very harsh. Okay, so those things are what you need is a mentor. So when you go back, you have to find out who is the right person who can actually train you, who can help you, who can just attend your OT and be there. That confidence building happens. And slowly then you don't need that, okay, you don't need to stress or pester that person to be always there, and you are actually able to do more and more difficult cases. So this is the way of learning, the proper way, and I am very happy that they have arranged both the models of training as well as huge number of patients are lined up. I think they have to cut short the number of cases. They are like more than 14 cases or something. So it's a good exposure that you all are going to have today, and I actually encourage you to do more and more of this dry lab training, and you will get a feel, because the electrosurgery which is used, it's in a very small area, contained area in the uterine cavity. The way you handle it, the way you move it, it's like driving. So try to make the most out of this today's workshop, and it will go a long way for your career. Thank you so much for giving me this opportunity, and I really welcome you all and appreciate your participation.
Thank you so much, sir. Thank you for a very elaborate and a detailed introduction for the workshop. So before we begin, you all know about the faculty. So the faculty would also like to know about you. So I would request the delegates to introduce themselves one by one, starting with the first delegate.
Hello everyone, I am Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪𝗂𝗪𝗂. I am practicing gynecologist in Nagpur. I have my own clinic in 𝗪𝗂𝗥𝗞𝗦𝗛, Nagpur. I have many infertility patients, as I have done my 𝗙𝗂𝗏𝗪𝗂𝗏𝗂 training of infertility. So I encounter many infertility patients, and I really feel difficult. I don't like I prefer doing hysteroscopy by myself. That is the reason I am here today. And since office hysteroscopy is a daycare procedure, so I would like to help my patients so that even for minor procedures they do not need to go to any other person. Thank you.
Welcome, Dr.
I am Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪𝗂. I am from 𝗪𝗂𝗪𝗂𝗪𝗂𝗪𝗂. I have my own setup in 𝗪𝗂𝗪𝗂𝗪𝗂𝗪𝗂. I don't have laparoscopy and endoscopy unit. I just want to learn the laparoscopy and hysteroscopy, and later on I can think on it.
Welcome, ma'am.
Good morning everyone. I am Dr. Nikita. I am Associate Professor in 𝗪𝗂𝗪𝗂𝗪𝗂𝗪𝗂 Institute of Medical Sciences. I am already doing diagnostic and basic operative procedures, but I want to learn more and more. That's why I am here. I am looking forward. Thank you.
I am Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪𝗂, practicing obstetrician. I am not into infertility practice as such, but looking forward for it. I will come to you.
Thank you so much.
I am Dr. 𝗪𝗂𝗪𝗂𝗪𝗂𝗪𝗂. I am practicing as a senior resident student in 𝗪𝗂𝗥𝗞𝗦𝗛𝗪 Hospital, and as I am starting my career, so I'm looking forward for hysteroscopy and laparoscopy workshops.
Welcome.
I'm Dr. 𝗪𝗂𝗥𝗞𝗦𝗛𝗪. I'm working as a senior resident in 𝗪𝗂𝗥𝗡𝗏 and 𝗪𝗂𝗥𝗡𝗏 Hospital.
Welcome, ma'am.
Myself Dr. 𝗪𝗂𝗥𝗡𝗏. I'm practicing since the last 5 years in Nagpur. I'm especially interested in infertility, in the office hysteroscopy, and just want to learn and have more fun in hysteroscopy. Thank you.
So now that we have been properly introduced, oh, we left out the minority in the crowd. Please, sir. Yeah, okay. So, welcome everyone, and let us begin with the first lecture, that is basically how to set up a hysteroscopy unit. Sorry for the technical glitch. So, I think most of our delegates are relatively new to the field of hysteroscopy. So, we'll be basically going through what all instruments are required in hysteroscopy, what all setup you require, what is the ergonomics for hysteroscopy, what distance in media to be used, what energy source to be used, should it be used, should it not be used. So, we'll be going through that. So hysteroscopy is nothing but visualization of the uterine cavity. So when we pass a building, we see a very beautiful building from outside. It's looking all fine. Structurally it is looking good. Aesthetically it is looking very good. But what about the internal structure? 𝗪𝗂𝗥𝗏𝗪𝗂𝗪𝗏. This is a very well-known Marathi man. But what about the inside? So when we do ultrasound, what we see is 𝗪𝗂𝗥𝗏𝗪𝗂𝗪𝗏. Everything is fine. But what actually happens? What is the kind of endometrium? Is there any pathology? Is there any fibrosis? Is there any adhesion? Is there any maybe space-occupied lesion like a polyp, like a fibroid, which is actually indenting the endometrial cavity? All these things cannot be 100% visualized through a ultrasound. So that is why we require a hysteroscopy. So what are the basic requirements of hysteroscopy? First of all, yes, you require a vision. So you require a telescope and a camera. You require illumination, because without illumination, ये खाली है. Then you require energy sources, hand instruments. And what else is required? Can anyone tell? Anyone from the delegates? What else is missing? Okay, we have a distance in media as well. Screen, yes, that is vision. Monitor, done. And there is one very important thing that is missing. That is the surgeon's interpretation. That is the most important thing in an hysteroscopy. What you see is what you learn. Until unless you haven't seen the pathology, you cannot diagnose it. So that is why you require experience, you require insight, you require some amount of theoretical knowledge. You need to have experience regarding what is normal and what is abnormal. So even when you have the best of technological aids with you, if you do not have good experience, if you do not have interpretation, if you do not have the knowledge of what is normal, what is abnormal, you are unable to do a correct and a 100% proper hysteroscopy. So let us move on with the first thing. उजाला है, light है, तो सब कुछ possible. So let us look at the light source. Initially we used to have yellow light, which was a warm light, and it was relatively a hot light. A longer time for hysteroscopy used to lead to burns. So then we shifted to cold source. In cold source we had the xenon light, and the power of around 175 watts was enough for a diagnostic procedure and for a 4mm scope. But when the era for miniature scopes, that is 2.9, 1.9, then your campo scopes, trophy scopes, all these came, there was an increased requirement of power supply. So a 300 watt xenon light is something which you should have to do finer and major procedures. Now xenon light is one thing, but the disadvantage of xenon light is, even though it is a cold source, it also tends to heat to some amount. And other thing is, जिसके लिए everyone is striving, पैसा. The electricity cost when you operate a xenon light is much more than even the hot light or the warm light that we used to use earlier. So then came the era for LED illumination. So first of all, it was economical, it was a cold source of light, it had around 50,000 lux of illumination, and that was enough for both hysteroscopy as well as laparoscopy. So this source can be a good source of illumination, not just for hysteroscopy, minor or major procedure, but also for major laparoscopy procedure. So a LED illumination or LED light source is something which you should have as an essential requirement for a hysteroscopy. Then moving on to optics. You have a wide range and a wide variety of scopes, ranging from your 4mm, which was the basic scope. It has 0 degree, 30 degree. Then came the era of 2.9 𝗏𝗂𝒄𝗏 scope. Dr. 𝗏𝗂𝒄𝗏 was the first person to introduce 2.9mm scope. Then we had the 1.9mm scope, even smaller scope. Now this is something which can easily and very comfortably used for an office hysteroscopy. The only downside or disadvantage of a 1.9mm scope is that it is very fragile. A small hit or a small dent to the scope can break the optics, and therein lies the fallacy of 1.9mm if we want to include the fallacy. Otherwise it is a beautiful telescope. The other disadvantage is it has a relatively small field of view as compared to a 2.9mm scope. So you have to reach to the parts which you want to examine. Then you have the integrated office hysteroscope, again introduced by Dr. 𝗏𝗏𝒄𝗏. Then you have the campo trophy scope. So now this scope is an integrated scope which has a diagnostic and an operative sheet integrated into the telescope. So you don't require a separate operating sheet or a separate diagnostic sheet. We'll come to the specifics in the upcoming slides. So again, 1.9 is a rigid scope. It has Hopkins lens effect, and the outer diameter including the operative sheet is 3mm. So now why is this a good scope for office hysteroscopy? Because most of the 90% of the females without a cervical stenosis, the external os diameter is around 4mm. So the earlier practice when we were using a 4mm scope, even after anesthesia, we used to give misoprostol, we used to have to do a mechanical dilatation to introduce the scope. Now the fallacy of that technique was that we could not observe the vagina, the cervix, the external os, and most important, part of the cervical canal, that is the endocervical glands. Now this is something which is the main problem in infertility patients. You take the patient up for IUI, you try to insert the catheter, and somehow you are not able to negotiate the internal os, and you say nahi os stricture hoga, problem hai, baad mein karenge. But the problem lies that there is, in most of the patients with chronic cervicitis or cervical stenosis, there is an anterior glandular hypertrophy which is completely obscuring the internal os. So when you do a hysteroscopy, you are able to negotiate the scope when you are using a 2.9 or a 1.9mm scope. That is why when you use a 1.9mm scope for office hysteroscopy, the overall diameter including the operative sheet is smaller than the endocervical glandular diameter. So that is why this is a beneficial use of a 1.9mm scope. Then you have a 𝗏𝗂𝒄𝗏 2.9 integrated scope. Now the advantage of this is that it has a gun handle like design. So your light source and your irrigation is on your handle. So you don't have that clutter of the light cable and the irrigation tube which is coming in your way. So this has an advantage of a clutter-free evaluation when you're doing a office hysteroscopy. Sorry, this is the integrated scope. This is a 2.9mm scope which we will be using, and the advantages and the disadvantages of this scope we'll be dealing it when we do the live, we do it on the patients. Then we have the Campo integrated 1.9mm scope. Now this has an integrated operative channel which is again a 5 French channel. So most of the hysteroscopy instruments are 5 French. So even if it is a 1.9mm scope, a 2.9 or even a 4mm scope, the operating channel is always 5 French. Now the advantage of 5 French is that even if you try to do a metroplasty, maybe a fundal or a lateral metroplasty, and inadvertently you just push the needle, scissor into the fundus or into the lateral wall, the entire opening diameter of the scissor is not more than 1.5mm. So the damage you are doing is negligible. So that is the advantage of using a 5 French instrument. Now with a further advancement, and you may be seeing it in the oscillator as well as in some operative sheets, mostly for fibroids, we are having 7 French instruments which are more sturdy and stout as compared to 5 French instrument. So the cutting of the maybe a fibroid polyp or a fibroid grade 0, grade 1 fibroid is quite easy with the 7 French instrument. Then you have various sheets, the diagnostic sheet, the operative sheet, and the integrated diagnostic and operative sheet. So now a diagnostic sheet in a 2.9mm scope is around, it gets the diameter to around 3.1 to 3.5mm, which is again less as compared to the 4mm diameter of the os. Now the advantage of this is that it just has one tubing set, that is the irrigation tube, so relatively less clutter. When you put in an operative sheet, it also has an outflow sheet, which you can either attach to a suction pump, or you can just keep it open. Now the advantage of using an operative sheet is that whenever you are cutting and you have blood in your field, you just open the outflow channel partially and the field is completely clear, because the fluid pressure is flushing out the blood first and giving you a clear vision. Then the integrated sheet, again it has a inflow outflow channel and an operating channel as well. So you just require one single sheet. It is more advantageous for a visiting or a freelancing surgeon when he just has to use one sheet, and that is relatively easy to manage. Moving on to hand instruments, there are a variety of hand instruments. You have your scissors and your graspers. Scissors can be blunt scissors, curved scissors, or sharp scissors. Then you have your biopsy forceps, your spoon forceps, your alligator forceps, and your Alice forceps. Now all these instruments have their various use. We will see them live in action when we do it on the patients. Now this is something which is very intriguing, but most of us are unaware how to use, or are little skeptical or nervous as to how much energy can be used. So when the hysteroscopy started advancing, we had the monopolar electrodes. Now when you talk about monopolar electrodes, just like in open surgery, it has an active electrode and a passive electrode. Now the passive electrode is again, or the return electrode is again in the machine. The plate that is used is the electrode which will take current back to the energy source. Now it is very important when you are doing any kind of surgery that the patient plate is snugly fit and it has a large surface area. When you talk about current, if that plate has maybe a small surface area of about, say, just like a pen or maybe a ruler, then it can still cause electric damage or a burn damage to the place where the plate is in contact with the patient. So if you do not have a very snug fit of the patient plate to the patient's body and you think कि नहीं अच्छा हो रहा है, कोई problem नहीं है, even then there can be electrical burns to the patient's body where the plate is partially in contact. So to avoid this, the electrosurgical units further advanced, and if there was a incomplete contact or a partial contact with the plate, the current did not fire. So that made sure that when you are using a monopolar current, you do not cause damage to the patient. In a bipolar current or a bipolar energy source, the active and the passive electrodes are very closely placed to one another. So you have your current from one electrode and then the other electrodes, then this just absorb it. Now we think that this current is actually causing the desiccation or the cutting effect or the coagulation effect. But actually the bipolar current is activating the sodium ions or the sodium molecules. Now this charged molecules, when they vibrate very fast, they bring about the cutting or the desiccating effect and not the current per se. So it is the vibrating or oscillating sodium molecules when we are using it in sodium chloride or normal saline solution, which is bringing about the desiccation. So I can safely say that bipolar is a more safer of the two currents, and it can be used safely with a ionic or a isotonic distension media. Moving on to electrosurgical instruments. So for a very long time we just had the resectoscopes as a electric cutting source, but now we have various electrodes which are again 5 French in diameter. They range from needle to hook to ball points, and they are available both in monopolar as well as bipolar. The advantage of bipolar again is that the active and the passive electrodes are on the same electrode, so you again create an arc. So these are relatively safe. So when you're starting your practice and you wish to use a current source, a bipolar current source, and maybe you do not wish to buy a resectoscope initially in your practice, this is something you can actually use as a source of energy, as an energy source for doing your major cases, like maybe bisecting a fibroid or cutting a polyp or doing a metroplasty or a lateral metroplasty, or maybe when you're using scissors, doing a broad septum with a scissor or a complete septum with a scissor, you keep on cutting and suddenly you see a big gush of blood and your vision is completely impaired. In such situation, you can put in a bipolar electrode, a ballpoint bipolar electrode, increase your fluid pressure and go ahead and just touch the bleeder. One small buzz of less than 1 second will completely clear your vision. So that is the advantage of these electrodes. Now moving on to the resectoscopes, the dawn of electrosurgical units which were used basically for myomectomies, hysteroscopic myomectomies and metroplasties. So resectoscopes are basically, they were for 4mm scopes. Now you get it for even 2.9mm scope. The resectoscopes for a 4mm telescope is the diameter of 26 French. For 2.9mm scope, you have a 22 French and an 18 French. Now, yes, the size of the resectoscope has gone down considerably, but the disadvantage of smaller resectoscope is that it will take you a longer time to resect out a myoma of 2 cm, 3 cm. It will take you maybe 15-20 minutes more than what you could do with a 4mm scope and a 26 French resectoscope. So that is the only disadvantage of a smaller resectoscope. But the advantage is that you require less dilatation, there is less damage to the cervical fibers and collagen, so less chances of incompetent toss, and you do not require to do maybe a cervical encirclage in patients once they conceive, because you have damaged the cervical fibers because of dilatation till Hegas maybe number 9, maybe number 10. So you avoid that when you're using a smaller French resectoscope. So the resectoscope has 4 to 5 elements. One is the outer sheet with the obturator, second is the inner sheet or the inflow sheet, and third is the active element with the electrode. So this is a short video about a Gubini resectoscope, and the important part is gynac resectoscopes are passive resectoscopes, they are not active. The urology ones are the ones which are active. So what do I mean by passive? So when you introduce a resectoscope, your electrode is well inside the sheath. You have to push the electrode out. So that is a passive electrode. And when you release your thumb, it resects. While in a urology resectoscope, the electrode is already out of the sheath. So you have to pull it back with your fingers. So this is the active motion and this is the passive motion. So why in gynac the passive one is used? Because if you are not well versed with how energy works and not able to control the current, when you introduce the electrode you might actually break it, or when you push it you do not have a complete control over the resection part. So that is why in gynae we use a passive electrode. One disadvantage that some people or some schools of thought is that when you use a passive you do not have enough power to completely scoop out the myoma. So some schools of thought still use urology resectoscopes for doing a gynae procedure. So it depends on where you are trained, how you are trained, and how comfortable you are with using an active resectoscope or a passive resectoscope. So the choice is completely yours. So, but I would suggest that when you're starting your practice, it is better to use a passive resectoscope because it has a better safety profile. Now we've heard about morcellators for laparoscopy. There has been a huge debate and a huge controversy about use of morcellators in laparoscopy. Because of that one case where there was spread of carcinoma. Then we had morcellator bags, in-bag morcellation, then again debate whether morcellating in the bag is of no use because you have already disseminated these cells when you are opening up the myoma or when you are doing a hysterectomy. That time you have already exposed the cells and disseminated in the cavity. So that is something which is an unending debate. But the use of morcellators in hysteroscopy has definitely revolutionized the practice of hysteroscopy. When you use a resectoscope for resecting a myoma, maybe a 3 cm or maybe a 4 cm, you start doing it and halfway you realize that you have no vision at all. The chips are completely blocking the view, and specifically when you're using a passive electrode, the chips get stuck between the electrode or the loop and the lens. So every time this happens, you remove the entire system, you remove the pieces or the shreds of the myoma, remove the scope, put in your obturator, insert the entire system, again withdraw the obturator, insert your scope along with the electrode. So this jugglery has definitely increased the time you do for a myoma resection. And then the use of fluid and the fluid overload that can occur is a life-threatening condition for a patient. A patient has come to you for a resection of myoma and would end up in a complication where she would require a ICU stay. So to avoid all these problems, Dr. 𝗪𝗂𝗏𝗏 came up with a shaver or a morcellator. It has the same principle as a laparoscopic morcellator. It rotates. So basically, I'll simplify it even further. You have a pencil sharpener, you have a pencil. You keep on rotating the pencil, it keeps on giving you shapes, strips and ribbons of the pencil, the wood. Similarly, this morcellator keeps on rotating. It cuts And the advantage of this particular instrument is that when it cuts, it sucks that piece of tissue inside. So your field of vision is always clear. You can decide when to stop. You can decide how much to proceed. Even a grade 2 myoma can be done with a morcellator. The other advantage of morcellator is when you have RPOCs with maybe calcification. This is something which is a wonderful tool which will completely remove the RPOC without causing much of bloody field. So you have a clear vision. So again, this is an advantage of the morcellator. Maybe if you have a fibroid polyp of maybe 1 centimeter, 2 centimeter, even then you can use this particular instrument. The other advantage is that you do not need to bisect the myoma to remove it. Many times we resect the myoma, small pieces are left or the globular part is left. Then what we do is we put in a ovum forceps and try to just remove it. Or we give methergin so that by the contracting action of the myometrial muscles, the chips would come out. But with a morcellator, you don't have to worry. You just put in your morcellator, it has an integrated scope. You put in your blade through the channel provided, the operating channel provided, and then you can just remove the chips. That is through the suction. The larger chips, if you are worried about it, does not come in the morcellator. We have 7 French instruments for that. You put in your grasper, take it out. So that is the biggest advantage of the morcellator. So it has a irrigation channel, it has a suction channel, and it has an instrument channel for the blade. So now this was all about instrumentation and equipment. So now there is something about patient preparation. So first and foremost, you need to take a detailed medical history and complete evaluation. Evaluation, I am not just talking about blood evaluation or physician fitness or anesthesia fitness, but you need to do your own sonographies before you do your hysteroscopies. Because many a time you can avoid a hysteroscopy just by doing a good ultrasound. So doing an ultrasound on your own, you get to know maybe what is the path of the endocervical canal, maybe is there any stricture at the internal os or the external os, is the cervix bulky, is there any active infection by means of the congestion in the adnexate, or are there 値보থিন cysts or 値보থিন follicles which are completely blocking the pathway to the uterine cavity. So you should do your own ultrasound. That is something which is of paramount importance. Informed and documented consent explaining all the advantages as well as disadvantages of the hysteroscopy should be taken. You do not require an extensive bowel preparation. You just require to give maybe an antacid a day prior and early morning and pre-op antibiotics. So this is an Eiffel Tower, and this is what we like the most, our hysteroscopy tower. So you have a monitor, you have the camera processor unit, then you have the light source, a good cautery, and a irrigation pump. So this is the basic setup for a hysteroscopy. Maybe you can forego the cautery in the initial part, work with the hand instruments, that is the micro scissors and the biopsy forceps. Once you have enough confidence, once you have done around 50, 60, 100 cases with hand instruments, you can graduate to the use of electrosurgical units. It is better to use a electrosurgical or the electric energy under supervision if you are a new endoscopy surgeon. Now this is what the ideal OT setup should be. Your anesthetist at the head, the trolley to the right side of the anesthetist. Then your monitor should be at a 45 to 60 degree angle where you are sitting. And your electrosurgical unit can either be in the trolley itself or an adjacent trolley where you can put your endomat, that is your irrigation pump, or your electrosurgical unit. On the right side, you should have your vaginal trolley, which will have your speculums, your dilators, your LSs, and basic vaginal instrumentation. The surgeon, and hysteroscopy is such a surgery which generally does not require an assistant. The only time you might require assistance in hysteroscopy is by picking up the instruments. or inserting into the operating channel. Even before that, you might require to just someone to just hold the vagina close so that there is a ballooning effect and you can enter the cavity very easily. So before we begin, what are the parameters that we have to check? As a surgeon, you yourself should check the monitor, the camera, the light source. If you are using an energy source, check if the energy source is working or not. Check the lithotomy position. Initially, you might have to train your staff as to how to give the lithotomy position. Even after training, sometimes you feel that the position is not right, because not all patients have the same BMI, the same height. So you might have to adjust your positions accordingly. One easy way of doing is having an Allen type stirrup. So Allen type stirrup is a stirrup which has its control to the feet of the patient. So you can just adjust the stirrups wherever you want, even after getting scrubbed. And check the patient's file, check the sonography. If you have done the sonography, go through your notes, make a plan as to what all I am going to do. Maybe I might encounter a problem at the external os, maybe at the internal os. Yes, I can see some fibrosis of the ostia. There can be a micro polyp that I can see. So your instrument should be ready when you are doing any hysteroscopy procedure. Any diagnostic hysteroscopy procedure can immediately turn into an operative. So you should be prepared for a complete operative setup when you are going ahead with the hysteroscopy. That is a diagnostic hysteroscopy. And always, always, always plan for the worst. When you are prepared for the worst, you won't be worried as to if at all there is any complication. You will be very comfortable in tackling. So this is before we finish, before we begin. So what to do once you have done with the hysteroscopy? Your recording system, you have to be sure that you have switched off your recording system. Otherwise, when you give a video to the patient or you show the patient the video, it will record everything that you are doing, your staff is doing in the OT. So you have to be very careful. Switch off the recording after you finish your procedure. Switch off the light source. Many a times you disconnect the light source, it lies on the patient's body, and there are times that it has caused serious burns to the patient. Hand over the camera and light source yourself to the OT technician or your rotating nurse. Keep your scope yourself on the trolley. Do not hand it over to your assistant. And always, 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 I cannot emphasize enough, always check for fluid deficit. This is something which would not show initially post-op, immediately after your OT is over, but it might come up maybe after 15 minutes, half an hour. The patient might be in pleural effusion, and that can land up into serious complications. So always, always, always check for your fluid deficit. So how do you check for fluid deficit? Either you have a good suction irrigation pump which actually measures the fluid that has been used and that has come out, or you can, once you have done your procedure, get your bucket, take it to the suction pump and measure the entire fluid that has come out. Check how much fluid is left in your bottles, add it and check for fluid deficit. So this is one of the most paramount important practice that you should do. Your procedure you will learn, but this is something you have to make it a habit. It has to be a muscle memory. Once your scopy is done, check for the fluid deficit. So most of the parts we have covered. Whatever doubts you will be having, we will be covering in the OT. So with this, I thank you all for a patient hearing. Thank you everyone. So next, I would like to invite Dr. 𝗪𝗂𝗏𝗪𝗏 sir for his ready? For his deliberations.
So before we move on, we have one more delegate, Dr. 𝗪𝗪𝗏𝗪𝗏 sir. Welcome, sir. So I would request you to give a brief intro about yourself and how much do you practice endoscopy, sir.
regarding the basic setup. Any question is fine, no matter how basic it is. As to what the irrigation part, we'll be covering it in the OT directly. So just an overview about the irrigation. You have the basic, what my boss used to call 𝗪𝗂𝗧. So it is just the end of the TUR set which goes into the bottle is cut. It is attached to a BP cup. You directly insert it into the normal saline bottle and just measurement of how much is the pressure of the fluid that you are getting into the cavity. The second is the pressure cuff. You put in your bottle in your pressure cuff and again inflate. The advantage over the 𝗪𝗂𝗧 is that you have a pressure gauge, so you know how much pressure is going inside the cavity. Now this pressure is the fluid pressure in the bottle, it is not in the cavity. So again it is a false sense of security ki yes, I am below 150, yes, I am below 200, but you do not know what is the pressure, actual pressure inside the cavity. So therein lies the fallacy. Maybe sometimes your assistant or your OT nurse just keeps on inflating, ध्यान नहीं है, सुबह से OT चल रहा है, last case चल रहा है, and dosing off, and she just keeps on inflating it without realizing कि fluid खत्म हो गया, air enters, leading to air embolism and complications. So that is again a fallacy about using a pressure cup or a 𝗪𝗂𝗧. Then you have your irrigation pumps. Now irrigation pumps, you will just get a basic irrigation pump which just has irrigation and no suction. Then you have your irrigation pumps which has a irrigation unit and a separate suction unit. Now the advantage of the latter one is that you know how much fluid is coming out. So you know, you can directly calculate the fluid deficit. So this is one of the best forms of pump that you can have in your unit. Not necessary, it is not a compulsion, it is up to your practice, because none of the equipments are cheap. Everything about hysteroscopy or endoscopy per se is an expensive affair, and when you're starting up your unit, it takes time. So take it slow. For hysteroscopy, yes, you can go ahead with a good camera, a good monitor, a decent light source, but I would suggest when you're starting as a surgeon, it is better to have a good safety profile, get a good pump, get a good irrigation pump. That investment will give you good sleep at night. So that is something you should always think about. You should weigh कि पैसा बचाना है कि चैन की नींद सोना है. That is something you have to decide. But when you do going for a setup, go get a good camera, good light source, and a good irrigation pump. Your telescope, definitely it matters. You have good telescopes, you have good sheets, and when you are doing in today's era, going for a 2.9 millimeter screw. 1.9 is still new, it is still fragile. It will be good when you go ahead, you have done hundreds, 500, 1,000 cases with a 2.9 millimeter scope, you know how to handle a delicate scope. Then go ahead with your 1.9 millimeter. And if you are starting a office hysteroscopy practice, then you can directly go ahead with a 1.9 millimeter scope. Yeah, sure.
Irrigation pump is instrument.
Yeah. Irrigation pump is Histromat, Endomat.
Okay. So after that wonderful lecture and a good introduction by Ambo, what I gathered from your introduction was that most of you are going to be starting it for the first time, or you are most of them are very new into hysteroscopy. So my lecture should not actually scare you, but actually it should make you more aware so that you do very good for your patients. Now the first thing is, you always hear about complications in various towns, and believe me, the hysteroscopy complications are the worst. You know, we think that, oh, laparoscopy is so difficult, they are going to cut, it's going to bleed. All that is anatomical. Okay, if I see a bleeding, I can catch it. At the most, if I am not able to do, I can open and compress it and call for help and all these things. The complications of hysteroscopy, they are more of physiological, and you don't see them and you can do nothing about it unless you really know and identify what has really happened to the patient. So suppose like there is air embolism, unless you know that this is an air embolism, you are helpless. You just keep on asking what is happening, and nobody knows. Panic situation happens. Okay. And hysteroscopy, by and large, the patients are very young, so we have to be really careful, understand what can go wrong in a young patient, what can go wrong in an old patient, whether she is compromised, and all these things I would discuss, and I'll give you brief idea of the complications of hysteroscopy. Now the complications can be of anesthesia complications, the instrument problems, which I think I will not go into Ashish's lecture about the troubleshooting. So I will just limit it to while we are performing a hysteroscopy, what can go wrong. Okay. So whenever a patient has a disease and that is affecting her, she wants to get rid of that, and so we attempt a treatment which should be less harmful than the pathology itself. Okay. But if you have a complication, then actually she was better off in the beginning with that pathology. So the first thing we have to understand is what is the incidence, and it is always very underreported. We don't have a technique of actually online reporting of our complications. So we always have very underreported incidence. But like I said, as I know, in many of the towns where the deaths have occurred, the patients were of hysteroscopy. I know from my friends and all that, and it is a very unfortunate event, but the hysteroscopy complications are very fatal. So we have to be very careful. It's not, when you know the things, that's why I said I don't want to scare you, but I want to tell that when you know about the problems, these things are very less. Okay. So next thing is why these complications happen. So the complications, you have to understand very basic things about hysteroscopy is there are blood vessels to the uterus, and we are putting fluid inside a contained area, and that fluid can actually leak from the cervical canal back, or from the instruments, or from the tubes. But the most dangerous part of this is it can go into the blood vessels. Okay. So there are very big venous channels that get opened when you perform a surgery, and this fluid, if you are not aware at what pressure the fluid, within no time the patient goes into a complication. So we have to understand this. Only this is a very important thing, is the mean arterial pressure. The blood pressure when you are putting fluid into the uterine cavity, if it is lesser than the mean arterial pressure, there is no way this fluid can go into the blood vessels. When this happens is when there is bleeding, okay, and you increase the pressure. I'll go back very basic to hysteroscopy. Why we put fluid, or why do we distend the uterine cavity? It's not only because you want to move the uterine walls apart. See, the blood vessels bleed, and that bleeding will not allow you to see, or it will not allow you to do the surgery. So what pressure you need is only to stop the bleeding, and that is very low. To stop this capillary bleeding, you need hardly 30 to 40 millimeters of blood. Okay. So when you put that 30 or 50 millimeters, immediately the bleeding stops. Whatever is the collected gets washed, and you get, within no time, you get a very clear vision. So ideally you require a very low pressure. But sometimes when you start performing the surgery, some bigger vessels open, and though they are at a higher pressure, so then you need to distend to prevent that leak. But when your intrauterine pressure goes more than the blood, it can gush in, and that pressures are very, very high, and depending upon what vessel you have opened, how big is the venous channel, all these complications happen. So if that is the reason, it is advocated that you use automated machines which actually check, and they do all that thinking and whatever changes have to be done. You cannot just later on fire your nurse that you did not check the air vent inside, you should have changed it, and all these things will not be, you cannot use this against in your defense. So in laparoscopy, when you put in CO2, it's like a steady unit now. Now the gas is not leaking anywhere unless you have opened the accessory ports. But in hysteroscopy, I said the fluid keeps on going. When the pressure goes more than 70, the ostia open and the fluid starts going into the abdominal cavity. That is the principle of office hysteroscopy. In office hysteroscopy, you don't want the patient to have pain. So where is the pain coming from? When the ostias open and fluid starts going, the patient gets pain. So that's the reason you do it at a very low pressure, lesser than 70. Okay? But in operative hysteroscopy, you sometimes need more pressure. There cannot be, lot of students ask me like, what is the ideal pressure? There cannot be an ideal pressure always. The answer to that would be, ideal is you remain below the mean arterial pressure. But then we are not always checking at every instance what is the mean arterial. Secondly, depending upon the pathology, the pressures are different. Suppose you have a very thick septum and the uterine walls are very stuck, like close to each other. Obviously, the pressure needed in that case would be more. If you have a grade 1 or grade 2 fibroid, if you give more pressure, that fibroid is going to disappear. It is going to go into the myometrium. So there you need a low pressure. So all these adjustments will, whatever discussion, it will come with experience. And we take it from me, with slowly as the cases increase, these things are not going to matter you anymore, because it becomes like your own habit and you understand with every case, and that's why it starts happening very easily. The only thing is, in hysteroscopy, it's not like laparoscopy where you can go on performing the surgery for like hours together. It has to be fast. We have seen very good hysteroscopists who do at very high pressure. But the trick is they finish the case in 15 minutes, 20 minutes. So they are adjusting all this physics is between time and the pressure. If you are slow surgeon and your pressures are very high, definitely the patient is going to have problem. The fluid is going to go into the vasculature, she is going to have fluid overload, and depending upon what you use, whether she will have electrolyte imbalance also. Okay? So this is what I was discussing. The fluid escape in hysteroscopy you cannot control, it is going to escape, so you have to balance this dynamics and prevent the complications. So the first complication, yesterday, Amok must be remembering, yesterday while having dinner, we discussed that his first case of hysteroscopy complication is this. So I have taken this as the first case. And he told me that the patient, unfortunately, the patient suffered. So just you need lot of counseling, talking to the patient, telling her that what procedure are you going to do. If you are doing office hysteroscopy, the trick of performing a good office hysteroscopy or successful is pre-operative counseling. The patient should be mentally prepared that what procedure are you going to do, where, and you have to keep on guiding her like before you do any procedure to her. So she is aware and she knows exactly what to expect, and that would reduce all the anxiety, and so Suddenly the patient, sometimes you go and they immediately, without telling the patient, you put a speculum, you catch the cervix, the patient can go into a vagal shock. Okay, so keep a watch on the pulse rate pre-operatively, keep a watch on the as soon as you start. So all these things should be taken care. The incidence according to RCT is 2.4%, so it's quite high. So what you do is immediately stop the procedure, put the patient in head low, and what happens in a vagal is bradycardia, atropine, immediately you can give oxygenation, and like it's a typical picture, the patient turns white, pale, and you have to identify and know that this is a vagal. Stop the procedure, don't think that okay, my anesthetist or the other staff will take care. So you have to stop the procedure and attend to the patient. The next commonest problem is perforations. This happens very often, and it is after hysteroscopy people thought that, oh, if this is happening with something with the vision, what must be happening to MTPs? So lot of MTPs go with perforation and they are not diagnosed until it's a major one where they have actually cut the bowel or perforated a vessel or mesentery. There is huge hematoma, patient is into shock, all these things. Otherwise, lot of perforations go unnoticed. So the perforations can happen right exactly at the dilatation. So this was earlier. Now we don't, of course, to begin with, see what is happening, why we are promoting hysteroscopy is we want to stop that blind procedure of DNC. And if you can do DNC, everybody who can do a DNC should be able to do a hysteroscopy. The only thing is they have to learn the attachments, adjustments, holding. Otherwise it is simpler than a DNC. So if you can put in a dilator blindly or an OM forceps blindly, you can definitely put a smaller telescope easier than a OM forceps. So that is when the perforation can happen. Perforations can happen while you are performing the surgery with the scissors. It can happen with the resectoscopes. But the difference between the scissors and resectoscope is in resectoscope you are using energy, and that could be very harmful and dangerous. So scissor perforations, like I said, bigger perforations happen and the scissors diameter is also very, very small. So even if you have a nick, like when you are putting a varies and you have a bowel perforation, you don't suture it unless the mucosa, it tears and the mucosa is seen. So same way, don't be scared of that scissor perforation. But if it's a energy source, then we have to be very, very careful. A complete evaluation has to be done. Laparoscopy needs to be done, and you have to identify whether there was some bowel loop behind it or it's happened to the anterior wall, posterior wall, whether it is bleeding still and all these things. So how do you diagnose that you have perforated? When you are seeing some good picture and suddenly the pressure goes down and the vision goes off, you know that, oh, I have perforated. So this is like you should anticipate. And obviously if you see the omentum and bowel, yellow color should never appear in a hysteroscopy. If you see yellow color, then immediately stop. If while in laparoscopy are very happy to see yellow color, oh, bladder dissection, yellow color, I am happy to go below it. In rectal dissection, I am very happy to go above it. So there I like to see that yellow color. But in hysteroscopy, you should not see it. And that is for the omentum. And if you are still not aware the perforation happened, your anesthetist will tell you, oh, her tummy is going up. The fluid immediately gushes and suddenly you will see they keep on changing the bottles and bottles of fluid is going into her tummy. So these are the ways of identifying perforations. Okay. Like I said, with perforations, there see the immediately if you go into the posterior wall, you have rectum there, you have great vessels there, whether you have perforated into the lateral wall, you have uterines. So be careful of anything, any suspicion, stop, evaluate, go ahead. Stop, evaluate, go ahead. Okay. So to prevent perforation, you have to anticipate which cases can perforate. So to begin with, very like if deep-seated myomas, there is a chance of perforation. Severe Ashermans, you don't know exactly whether you are going in the central plane. Why it happens is you can keep on going into the posterior wall and suddenly you will go up. into the posterior abdominal cavity or into the anterior abdominal cavity. So all this you can prevent it if you anticipate. You can keep an ultrasound. I am not a very big fan of performing hysteroscopies under ultrasound because you don't see it so well. Okay, all these adhesiolysis. What I do is I do intermittently stop. We put a probe, identify how much depth has been achieved, because it's complete assurance. You don't know exactly where you are going. But I would rather prefer to do it under laparoscopic guidance. Okay, to understand what is the position of the uterus, whether it's a fixed uterus, retroverted, anteverted, and accordingly you can go in. Because when you have severe assurance, you have the only landmarks in hysteroscopy are ostia. And when you don't see the ostia, you are clueless. Okay, so there you have to be slow. You have to go step by step, think what is this, what tissue it could be. Those crisscross fibers, unless you have seen these cases, you will not understand. Sometimes you see vessels pulsating, you have to understand, okay, this is a vessel. There are sometimes RBCs seen flowing into the uterine. We will show you, demonstrate how they look. So all these things that should be imbibed, these images. The more and more images, the more and more videos you see, it is more learning. You don't have to understand, okay, I have done 20, now it is my 21st, 20th. No, you could see hundreds of cases of that sort. So your numbers you should not get confidence only with your numbers. You can actually learn more by watching other surgeons' videos, and always thinking and being very receptive is, this is new, okay, this is new I have learned today. So then it gathers and it helps you when you are performing the surgery. Infection, yes, of course, any procedure is a contraindication. If you have severe infections, you should avoid it, treat it initially and then go ahead. Spreading of cells, there are plenty of papers to show that hysteroscopy is done in CA endometrium or any uterine pathologies. The spreading of cells is no more a concern. You can actually do a hysteroscopy at low pressures and take a targeted biopsy. Lot of times your DNCs are they are negative in spite of having a pathology. So it is always better to visualize and take a targeted biopsy. Your chances of catching the diagnosis is much better. Okay. Now we come to the main part, the fluid complications. See, understand that there are two problems with the fluid. One is the volume itself goes into the intravascular circulation. So what you have is a fluid overload, but the fluid is somewhat similar to what your body has. So isotonic, whatever is the concentration of your blood, if you are using something like that closer to that normal saline, so when normal saline goes into the blood vessels, the problem is it is only more fluid. So that is fluid overload. When you are using some other distension media which is not equal or not actually matching your blood, then the problem starts. So suppose you are using glycine or any other distension media. When you have these hypotonic solutions, the circulation will go from blood towards that fluid. Okay, so it will deplete the electrolytes in your blood, and that is very dangerous. So when you have electrolyte imbalance, that is the big problem. And when you have electrolyte imbalance, if you have little bit of imbalance of sodium, immediately the brain gets affected, hyponatremia. And if it is not detected and it goes unrecognized for a long time, it is irreversible. So there is the problem. But fortunately, you have come for a conference or you have picked up this technique when things have really settled. All these problems were faced by the initial generation. That understanding is going to be your first stepping stone, that you can actually avoid all these electrolyte imbalance causing fluids by going into bipolar. Why at all go into the problems of monopolar? And now you will see in most of the conferences, no faculty is using monopolar current. So it is good for you that you are not in that era of a debate or complications earlier to that, then debating, and now it is already settled. The water is very clear for you to swim now, okay? So we can use normal saline and use bipolar. You can go in with smaller resectoscopes, better energy sources, and also the technology is improving. You know, initially the problems of electrosurgery was happening. The active electrode is going in current. They are receiving the passive electrode, like what Amol was telling. You should apply the plate very correctly, and it should be very close to the active electrode and all these things. Now the machines are so smart. If your active current goes in the patient and if it is not received, the machine stops. So these are like return electrode monitoring. If there is no, and later on in just deviating from the topic, now machines are also available where if you have current loss from the active electrode itself, AEF, active electrode monitoring machines, if the 100 unit is delivered and it 100 does not go to the tissue, the machine stops. That is the best thing that can come. Okay, so you have to understand about the fluid and the electro energy sources to actually prevent. So if you see a very good paper, you know which surgeries cause maximum complications. So you should be careful. If you are a beginner, you should take simpler cases. This is like this step ladder for vaginal hysterectomy. You want to learn vaginal, but if you take previous 3 cesareans, very large uterus, definitely you are going to fail. You are going to lose your confidence. Go for simpler cases and avoid all those complicated cases where complications happen, like the Asherman syndrome, deep fibroids, or very adherent placenta, retained placenta, endometrial ablation procedures. These are all difficult procedures. So you can actually avoid doing them individually, or you can take help. You can call your seniors for monitoring, and then you can gradually go to these cases. What is recommended is to use these automated machines because they actually adjust the pressures. Whenever you have fluid loss, automatically the pressure will go and be maintained. So it will not be a very difficult proposition to happen. Okay. Now the distension medias commonly used are the gravity method, the 𝗪𝗂𝗏𝗪 method, air pressure Vistromax. The problems with the gravity is you really don't have exactly what is the pressure, what is amount of fluid going in, and how much is the intrauterine pressure. So nothing is there. It is just good vision or bad vision. That is what you understand, and you keep on shouting at your assistant. Also, the pressure cuffs are not very uniform. So what is recommended is these electronic pumps where there is a constant pressure and dynamically adjusted pressures. Okay. So I think this was discussed and is going to be discussed more in Ashish's lecture for fluid. Your lecture is on fluids.
Yeah.
So I'll just go now. I'll not go into his lecture. This is the I was talking about the fluid pressures. Okay. The mean arterial pressure and your intrauterine pressure. It should be always lesser than the mean arterial pressure. The fluid should not escape into the vessels. See, if you are doing diagnostic hysteroscopy and you have not given any cuts or any incisions on the uterus, there is no question of that going into blood vessel. The only thing that can happen is it can go into the tubes and it can leak out of the cervix. So you have to understand, if this will come, the fluid overload or the fluid electrolyte imbalance will come when you are actually cutting. Okay, so when you are performing myomectomy or you are doing septum lysis and you are gone into the myometrium and the blood is going in, the fluid is going into the blood vessel circulation, only then these problems happen. So you know which cases can have fluid overload, which cases can have electrolyte imbalance. Okay. Bleeding, the problem is when bleeding happens, we increase the pressure to C. Like I said, you need distension to C to stop the bleeding, and that is the reason. So whenever you have bleeding, you immediately stop the procedure, because it has been shown that when you stop the procedure, the fluid absorption stops and lot of complications are avoided. If you go ahead just trying to somehow figure out where is the bleeding coming from, what should I do, whether it's a big one, in that 10 minutes only the patient can really go into irreversible problems. So if you have bleeding, just wait, stop the procedure, call for help, and then you can again take over. The anesthetist will guide you what is her status at that time, and then you can go ahead, and lot of these complications can be avoided. So the most preferred method of distension is normal saline. Most of our energy sources work in, they are bipolar. Even if you have a needle, it is bipolar. See, I found that lot of new students, they have a wrong concept that pointed means monopolar and flat or some different shape means bipolar. It is not like that. Okay, you have an active electrode and you have a passive electrode. You pass current, goes into the patient, operates and returns to the machine. Now when you keep these two away from each other, that is what we traditionally are calling like a monopolar, if you have a patient in between. Okay, but when you bring this active and passive blades very close to each other, that can be brought into very small instruments, like making it into the shape of a needle, where you have an active blade and a return blade, or you have a loop where you have an active loop and a passive loop, and what is the tissue only that comes between these two is the patient. So there is no difference into like an active and passive is only because monopolar and bipolar is like. So both will have some current should go and some current should return. It should happen in both monopolar and bipolar. It is upon how close they are kept. It is nothing to do with the shape of the instruments. Okay, and it can come into loops or it can come into needles as well. The fluid deficit that can be allowed in normal saline. Why? The second reason why we recommend normal saline is the safety margin is much bigger in normal saline. You can have a fluid deficit of 2000 ml normal saline. Okay, but if you have some other distension media which is hypotonic, the fluid margin of the deficit is only 1000 ml. Okay, and sometimes if your anesthetist is very aware and he picks up the rising pressure, diastolic blood pressure, that is an impending sign for pulmonary edema, and he should immediately tell you, stop, I want you to wait for some time. Okay, so immediately stop the surgery, check the electrolytes, check, give IV diuretics because you want to prevent pulmonary edema. Okay, and monitor urinary output and electrolytes. See, this is the study which I was telling. Temporary cessation of procedure for 10 minutes, overall reduction in the distension media, systemic absorption, and that actually prevents the complications. So just wait and take a break, evaluate the patient, and then you will see. Okay. Now, sometimes when you anticipate that this patient is going to bleed and there is a chance that fluid will go into her vasculature. Okay. So what you can do is use vasopressin. I think in more detail would be explained. I am actually stepping on his lecture, I think, but it is in the same complications. That when you give vasopressin, the vessels will constrict, fluid will not go into the circulation, the myometrium constricts, and you have a better safety margin. Okay, so it depends upon your duration of procedure. Like I said, slowly with time you have to understand that your procedures are finishing faster, because it directly has relation to the complications. When you finish the procedures faster, there is definitely less fluid used, less chances of complications. The total volume of fluid used has to reduce. So if you are not using automated machines, definitely your volume of fluid used is more, and that's the reason for complications. And if you don't have these machines which measure the deficit, then you are at a risk of actually using more fluid, and depending upon the pathology. So slowly, I think now according to the guidelines, we know that again the same thing, the problem with hypotonic glycine is encephalopathy. When you have hyponatremia, there is brain edema and encephalopathy, and if it extends for a long time, like I said, that patients have experienced blindness, and it is the myelin sheath is destroyed and it is irreversible. So better we don't go into that fluid distension, fluid meters. So I think now the complications and the fluid management system would be explained by Ashish. If you have any questions regarding the complication, and one more complication which I would like to discuss is the air embolism. Okay. See, you have to be aware when this air embolism happens, when the air from the operation theatre environment, it goes into the circulation, and the problem or the culprit is that there is nitrogen in that air. We are using CO2, okay, O2, if you put O2 can get absorbed, CO2 when you are distending the abdomen it gets absorbed. This nitrogen does not get absorbed and it forms like a bubble, and it can go into the smaller vessels and block cardiac block or cranial central nervous system problems. So that is the reason we want to avoid this air. And this air can go if you are using those gravity methods or the blood pressure methods, where the fluid is over and you still keep on pumping air into the system. So you have to tell that when it reaches, it's not, the bottles are not to be changed when they empty. It has to be have some safety margin, because when they completely empty, there is always an air column there. Okay, and just 100 cc is enough to really cause a severe fatal problem for air embolism. So it is that safety margin is so close. So it has to, you have to be very, very careful in using. And this air bubble, lot of times the air can even go with the change of instruments. Like Amog explained, when there is a small piece of tissue between the loop and the lens, you keep on trying to remove it, does not come, then the whole, it takes long time. You have to really come out, dismantle everything, clean it, again go in. So with all these procedures and repeated multiple procedures, there is a chance that air embolism can happen. So you have to be careful, and that's the reason why we new safer technology is coming into play about the tissue retrieval systems, the oscillators. Okay. So when air embolism, now I don't think many are doing this under spinal, either it is office or it is the general anesthesia. So under general anesthesia, the patient, it is slightly detected or picked up a bit later when you have some changes on the monitor, ECG changes, bradycardia or tachycardia. But if you are aware, now I had this only once, okay, but I was actually talking to my nurse that okay, I think you should change the fluid and all that, and in that short notice the air entered. So immediately I was aware, oh, air can go, and at that very moment there was like some changes in the ECG. You understand? So it was lucky that I was anticipating something and it happened. Otherwise, it's a very, very risky procedure, and you need some anesthetist who really works into cardiac OTs. Fortunately for me, on that day, he was very efficient. He immediately gave her to the left lateral position, Durant's method, what it is advocated. And because the air will come up into the right column, it will not go into the circulation into the brain or heart. So this is the method which should be employed: reverse 𝗪𝗪𝗪𝗪 position, stop, ventilate, keep a watch, and you can monitor this patient. So finally, to end my topic, like I said, it is not to scare you at the beginning, it is just to orient you that what can go wrong. Now when you are aware, then you know what you should anticipate, what you should act, how you should act in that particular case, and prevent these complications happening in your practice, because I know they are really demoralizing. Complications really take away your confidence, and so I think it is going to, their complications, when you anticipate, it will not happen. If you don't anticipate and you try to take that, oh, this is such a simple surgery, then the complications happen. Okay. So if you have any questions, I will be glad to answer them.
Any questions from the audience?
Yes.
Sir, can we use injection atropine and buscopan before doing office hysteroscopy to prevent vasovagal
To prevent. So it is not recommended to give treatment to prevent vasovagal. When you are doing office, it can happen when the patient is unaware and suddenly you have started, or you are using very crude instruments like very sharp instruments and it causes severe pain. Okay. So to prevent, we don't give atropine. See, atropine will increase her heart rate. Okay. And then you are going to put lot of fluid. So you have tachycardia and fluid overload. Definitely that patient will go into pulmonary edema. So to prevent the vasovagal, you will actually predispose her for some other complication. So it is not recommended as a routine practice. Okay. But the anesthetist, as their pre-medications or preparation, they would take a call into the other medications and to calm her down and prepare her. Office hysteroscopy, like I said, the whole trick and the game winning is the counseling and the patient accepting, okay, I am ready for this little pain or this discomfort, and then she would cooperate. It's finally the patient has to cooperate with the surgeon's procedure. Yeah. But that's a good question. Yes.
What should be the setting
For
stroke mat?
For the endomat, that's what I said. Mean and arterial pressure, if you take 100 millimeters, then the pressures have to be lesser than that. Okay. For diagnostic, so definitely it has to be lesser than 70 when you are doing an office hysteroscopy, because you don't want her to have pain. You don't want the fluid to go into the abdomen. You don't want the ostias to open. So lesser than 70 for diagnostic, and it is very much possible. You need just more than 40 to prevent the microcapillary bleeding to see, and you don't want to go more than 70 to prevent pain. So in between that is all the procedures. There are surgeons who actually, when they do diagnostic, they go with slightly like up to 90, 100, the fibroids and septums. But when they operate, they actually operate it at a very low pressure. You will feel that, oh, I cannot see anything, but they have really developed their style where they bring down the pressures, but they know, okay, the fibroid is on the anterior wall, it is 2 centimeters, I am going to operate here, and then the vision is also there for them. So they purposefully, voluntarily, they do it at low pressures. And there are some surgeons who do it at a very high pressure, but they are very fast. The only difference is they compromise it on time. They feel that, okay, the pressures, increased pressure, actually they have different theory of counteracting, is that they feel the increased pressure compresses my vessel and I bring it. It is only until you are cut into a vein, a venous channel has opened, then nobody is right. Anything can happen in that case. So that is the reason for overall, when everybody is learning and everybody is not fast, we have to have standard method which are safer. And the safer would be to be on a lesser side of pressure.
Any other questions?
Okay. So thank you very much for your patient listening, and we go to the next lecture.
Next, I would like to invite Dr. 𝗪𝗂𝗪𝗂𝗧𝗔𝗏 sir, who will be talking about distension media and its complications.
Good morning, friends. In 1869, 𝗪𝗂𝗪𝗏𝗏 first introduced his scope, contact scope, in the uterus in a 60-year-old lady, and he diagnosed the adenomatous polyps, endometrial polyps. So cauterized it with silver magnet, and that was the origin of the see and treat. After that, so much of the evaluation of this hysteroscope, as far as the optics is concerned, lens is concerned, the light source is concerned, and the distension media is concerned, and how to deliver that distension media. The same principle were used by the surgeons when they are doing the cystoscopy. what happens? This urologist, they are using their cystoscopy and practice of cystoscopy in almost all the patients. They follow that principle. When आपण राहिलो मागे, we are not using this technology or this mode of this investigation so often. And again, this concept of see and treat was again rejuvenated by 𝗪𝗂𝗏𝗏𝗧𝗏𝗏 when in almost around 2004 he invented the office cystoscope and he conceptualized the practice of office cystoscopy, that you have to do this contact cystoscopy procedure not in the operation room, rather in your OPD. These European people, they call we call OPD chamber, they call it as office. कारण की त्यांच्या इथे काय व्हायचं की पेशंटला ऑपरेशन रूम मध्ये न्यायचा त्याचा खर्च आणि त्या ऑपरेशनचा खर्च तो एवढ्या पटीने वाढतो की ते त्यांनी अवॉइड करायला त्यांनी आणि टू यूज दिस गुड प्रॅक्टिस ऑफ सी अँड ट्रीट ही स्टार्टेड डुईंग इट इन द ऑपरेशन रूम इन हिज OPD chamber itself, and it has revolutionized. That was really a paradigm shift in whole journey of this history. All this evolution, all this research went parallel. Research about the optics, research about the lighting system, illumination, and research about the distinction. Why do we require the distinction? What are other procedures where we again require this distinction? What happens? These are the closed cavities. आपल्याला लॅप्रोस्कोपी करताना डिस्टिंक्शन लागतंय? Do we require distinction? Yes, we require distinction. We insufflate the cavity by carbon dioxide. And when you distend the cavity, then only you can see and you can operate. Uterus is also a tubular structure, which in resting phase it is closed. Now first you have to separate the uterine wall, and after separation you have to distend the cavity so that you can properly visualize the cavity and operate upon in the cavity. Therefore, without distension media, no surgery. Let it be the cystoscopy, let it be the histoscopy, let it be the orthoscopy or laparoscopy. These all procedures is not possible without the distension media. We use any of the distension media in this patient. Therefore, it is must to use the distension media. Initially, Rubin's, as you know, this Rubin's cannula or Rubin's test in the whether these tubes are patent or not. It is really a milestone in the history of histoscopy that Rubin used first he used the air and then he started using the carbon dioxide. Therefore, as far as this distension media is concerned, we can broadly divided into the gaseous and liquid. Therefore, first is the gaseous medium that started with the air by Rubin and followed by it was replaced by the CO2 as it was much as Sandesh told that very high chances of the air embolism. Therefore, air is being replaced by CO2. What is the advantage of CO2 over air?
The blood. It absorbs by the blood. It is isotonic.
Isotonic is always with respect to the fluid.
It is miscible with the.
Basically, CO2 is a body gas. CO2 is a body gas. Every time we inhale, we exhale CO2. Or venous blood, it is having the CO2. Our centers, we are having the CO2 centers. And body is more sensitive to CO2 as far as these centers are concerned than that of the oxygen. Therefore, CO2 is a body gas. If there is air embolism, as Sandesh told, CO2 is not the problem. Air is the problem because air contains the nitrogen and it causes the air embolism. Therefore, CO2 is a body gas. Therefore, body can eliminate the CO2. But inherent problems with CO2 where we use the CO2 as the distension media in hysteroscopy. Because what happens many times you are doing the hysteroscopy in a patient of AUD where already there is blood in the endometrial cavity. Therefore, this blood it does not get washed out. Sometimes there might be the bubble formation. If this cavity is clean, जेवढं चांगलं विजन CO2 चं भेटते तेवढं चांगलं विजन डिस्टेंशन मीडिया मध्ये नाही भेटत. This is a fact. But the cavity it should be clean. You will get beautiful vision with CO2. But it does not wash the cavity. And second is the chances of the bubble formation. The third most important is that you require a very specialized instrument, machine to pass this CO2. Means you require some form of insufflation. But you cannot use that insufflator which you use normally in laparoscopy. You cannot use it here. Because laparoscopy insufflator is always a high pressure system. Here always you have to use the low pressure system. Sandesh has nicely displayed that diagram of this pressure system related to the